Okay, good morning everybody. My name is Ryan Springer, Executive Director of the Dania Institute, and we're happy to be one of the partners with MADC on this conference. I think we had an excellent turnout the last couple of days, great conference, great speakers. So I'd like to give a round of applause to the MADC and that team for doing this actually. And so today, I guess we could call it the Dania Institute Day. So we're sponsoring the speakers for today. We have two guest speakers. So we are sponsoring them today. We're also recording. We've been recording all week. So I'd like to thank Simone for her job this week. And you will be having access to the videos. They'll be on the MADC website once we have the production done, as well as on the Dania Institute website. So you have access to those after the conference as well. It'll take us a couple weeks for her to go through it and edit, but you have them to share with the rest of your team once you go back to the office as well. A couple things stood out for me this week, and I hope it stood out for everybody as well. I mean, we had great speakers. Mady and Kathy really stood out to me yesterday, and the message was very clear to me. We have to work with primary care. I think the quote they gave was, we are either at the table or we're on the table being cut up. I think that says it. But at the same time, it's not a scary thought. I mean, you've heard examples all week about how individual programs are doing it. So there are examples out there of how to make this integration work. And I think the goal is, don't recreate the wheel. There are examples. Contact your counterparts who are doing this already, whether in the state or outside, but you have examples of how to do this. We had a group yesterday, we had a little work group, and we did a project in Baltimore City with some providers in Baltimore. And one of the things that they said, they thought it was this monumental task of trying to integrate their programs. And after going through the project, it was a collaborative project with Niatex, they now have a skill set that they used on one small project, but now they can take that skill set around how to change their program, and they feel comfortable doing that. So going forward, whatever change is coming, they have a tool set and a skill set to use. And I got that as a theme throughout this week. So I hope you got those messages as well as you go forward, and you don't feel overwhelmed, but you feel as though there are resources out there for you as you tackle this integration effort. And today, we're going to start with our first speaker, Dr. Ijeoma Achara. She's worked extensively in the behavioral health field. Currently, she consults with state and local government entities, as well as provider organizations around the country regarding the provision of recovery-oriented care. Now, I've known Ijeoma for a number of years now, actually, and I think I can safely say if there's a recovery effort happening somewhere in the US, and sometimes outside of the US, Ijeoma is involved somehow. She was in Connecticut, involved in the work happening in Connecticut, in Philadelphia, and she consults around the country, as I said, on whatever efforts are happening around recovery. She worked with Bill White for many years, so she is a national figure in this area. And to me, the recovery-oriented care really is the linchpin when you're talking about integrated care in ACA. And so I'd like to welcome Dr. Ijeoma to present to you today. Before I go, I'd get killed if I didn't do this. You were given some forms in the beginning, some evaluation forms, a consent form, a white consent form. Essentially, we needed to fill out these forms so that we can continue doing this work in these kind of conferences. We needed data, the evaluation information from it. So the consent form is so we can follow up with you in 30 days to see if you're utilizing the skill sets that you learned. But then there's a final evaluation form. There's a blue and a green page. And this gives us the data on the conference for this week, your reports and how the conference went. You've been also filling out some forms at the end of every speaker, essentially. That's a speaker evaluation form. This is for the entire conference. So we'd ask that you please fill those out. Those will be handed out to you if you haven't already completed one. So thank you very much. Dr. Jean.
Good morning, everyone. Good morning, everyone. Can everybody see me if I hang out down here? No problems? It's all good? Okay, I'm going to put my phone here. I'm not expecting any phone calls, just so you know. I just need to track my time. It is great to be here with you, and give yourselves a round of applause for hanging in there day 3. Woo! You guys are the diehards, the one who are determined to suck everything you can out of this conference, right? And make sure you go back to your agencies with something concrete that you're ready to implement and run with. I just want to thank the Dania Institute and Ryan and his whole team, Linda, for inviting me to be a part of this with you today. Recovery-oriented systems of care is my passion. Live, breathe, sleep, eat it, and I'm just so excited about the opportunities that we have for us in our field right now. So I have about an hour and a half. I'm gonna cover a lot of material, go really fast. How many of you have, I've been in Maryland a couple times, and I'm just curious about how many of you have heard me speak before? Just a couple, okay. So what we are going to talk about today is the intersection of recovery-oriented systems of care and all of the changes within the healthcare, broader healthcare field right now. How do those two come together? I want to start with some of the, I know I'm supposed to have a strength-based approach and not start with the challenges, but I'm starting with the challenges. Because as exciting as it is right now in terms of the times that we're in and the extraordinary opportunities that are in front of us, we also have tremendous challenges. And one of the challenges that I see is just, I think, system administrators and providers having to contend with multiple changes simultaneously, having to prepare yourselves not in one way, but multiple ways across multiple domains, multiple levels of your organization simultaneously. And as Ryan said, I consult in many places throughout the country, really around recovery-oriented systems of care, recovery-oriented care, healthcare reform, behavioral health, primary care integration, and this is what I see. The reaction to the field is that people are like on information overload. As exciting as it is, there are many feelings that get stirred up. Anxiety, yes, there's the passion, there's the interest, there's the confusion about how do we get started, how do we proceed, what are the next steps. And what I'm proposing is that today we're going to talk about how do you all remain relevant, not just survive, but how do you thrive within this changing healthcare ecosystem. And I believe that if we focus on the triple aim of the Accountable Care Act, that will put us really in a good position to be successful. And I know we don't even know if healthcare reform is going through and who knows kind of where that's going to land. But if we look at really what the goals are of healthcare reform, not the strategies. The strategies are insurance coverage reform, insurance expansion, all those things that are being debated right now. What's not being debated is that we need better care. What's not being debated is that we need improved outcomes and that we need to reduce costs. Those three things, if we keep them central and not get caught up in the how, when, why, who, what, but we're looking at what our ultimate goals are. That helps us stay focused on what we as providers, as system administrators need to do. And I feel right now there's kind of two general stances in the field. One is folks who are being reactive, waiting to see how things are going to come down. How is this going to play out? I'm not going to make any moves until I know for sure X, Y, and Z is happening. And the other is proactive. Those who are saying, regardless of how the details play out, this is the direction of the future, and I need to position myself and my organization for success. The fact that you all are in this room today shows me that you are the proactive ones, right? Yeah. Amen. Okay, I'm going to talk at you. I need you to talk back. Don't just look at me, right? So let's try that again. The fact that you're in this room today means that you're the proactive ones, right? Yeah. Woohoo! All right, we're getting going. So, given that, what I'm really excited about is it feels like two streams have been winding together. All this stuff has been happening in terms of physical health, primary care, changes in that whole, system and structure. And in our field, in behavioral health, for the last decade, we've also had changes happening in our field. And they have been evidenced by the recovery transformation efforts that are happening in multiple communities around the country. And when we look at what are the historical forces that have been pushing this recovery transformation process, I love this slide because it points out that historically, and probably now more than ever before in our history, we as a field, particularly of substance use disorder treatment providers, do a better job than ever before of helping people detox, stabilize, and initiate their recovery, get going in their recovery. Would you agree? Our technology around that and our ability to effectively do that surpasses anything that we have achieved in the past. What we haven't done as well is help people maintain their recovery and rebuild their life in the community. And that is evidenced by the number of people that you guys see more often than I can tell you. I'm not telling you anything you don't know, of people who come back over and over again, right? Accessing treatment more than once. That shows us that, yes, although we have made tremendous strides in one area, in another area of the recovery continuum, we still have a ways to go. If we look at other historical forces and things that are happening in terms of the structure, the outcomes, the functioning of systems, not here in Maryland, but just around the country. This is national data. And what we see is that we have a huge unmet need. Could I get some water, please? If somebody could pour me a glass of water, that would be great. We have a huge unmet need. Only 10% of those who need treatment in a given year are accessing services. So 90% of those who need treatment aren't accessing services. We have low pre-treatment initiation rates. That means from the time that somebody either calls you, thank you so much. See how efficient you all are? Thank you so much. I appreciate it. So from the time that somebody first calls to say, hey, I need treatment, it's usually not that. It's, hey, I was told to call you, but we won't go there. Or somebody else may call and say, hey, such and such needs treatment. To the time that they actually walk in the door, what proportion of people do you think drop off during that whole period of time? Any guesses? A lot. Yeah, it's about half. So from the time that people initiate contact to the time they walk in the door, half drop off. Then of those who do come into our service systems, again, around the country, we have 50% completion rate. So we've started at 10% of those who need it, access it. Then we're getting to those who make contact, only half get in. Of those, that half that gets in, only half of them complete. Then we look at, let's skip to outcomes. Of those who complete, our data shows that most people resume use within 1 year, and of those who do, it's usually within the first 90 days of completing treatment. So there's a vulnerable, critical period of time when people are most vulnerable to relapse. And we've typically said, great, graduate, vaya con Dios, go with God, live your life. And we're no longer there, but who is there? Cousin Ray Ray, who's using, and the drug dealer, and whoever else. And so people are at this vulnerable period without the necessary supports that they need to sustain their recovery. So what we get is, we have this revolving door of treatment. In the mental health community, there are similar challenges. The unmet need is less. It's half of those who need services are accessing services, but very low retention rates, particularly in outpatient care. People come in, when I was being trained, the average length of stay was 1 session. People would come in for an intake and not come back. Low dose of treatment, high recidivism, particularly in higher levels of care, people coming in over and over again. What I don't have here is in the mental health arena, particularly for those with serious and persistent mental illness, we kind of have opposite challenges in mental health and addiction. In addiction, we have people who come in for a short period of treatment and then we discharge them without any continuing support. In mental health, people with serious and persistent mental illness historically have lived in our treatment settings. They have never left. And so we have an institutionalized system, even though it may be a community-based system. When I was in Philadelphia, the average length of stay years ago in the day partial programs, the day treatment programs, was 17 years. 17 years. And when I did focus groups with people who were in those programs, they said to me, we thought the only way that people could leave this program was in a box. Because they had seen so many of their peers who actually came up, grew up in the program with them and died. Because we know people with behavioral health challenges die at a much younger age. So we have serious, serious challenges. We're doing a lot well, we're doing a lot right, but nationally our data shows us that things need to change. So I have 2 key messages. I'm not wasting any time, I'm cutting to the chase, because I know we're on day 3, you're burning out, you're just holding on by fumes here. So 2 key messages. The first is, we gotta get our house in order. We're talking about all this, service integration, integrate with primary care, blah, blah, blah. Wonderful, wonderful, I believe in it, it's gonna happen. We are definitely headed in that direction. My caution is, what is that integration going to look like? If we integrate with primary care, with the challenges that we currently have in our service delivery system, what is miraculously going to change tomorrow about our low engagement rates, low retention, no-shows, our poor kind of outcome levels? What is going to change? If within the context of the complexity within our system, we haven't addressed those challenges. I'm sure you've heard over the last 2 days more of the complexity that takes place in the context of an integration effort. The fact that we integrate alone and that we are now either partnered with, co-located with, working with, integrated with a primary care provider is not going to address all of those issues. My caution to the field is, we can't put the brakes on all of this, but as we go through this process, let's make sure we give ourselves the greatest potential opportunity for success. That we're not setting ourselves up and reinventing things that have not necessarily worked to the best of their potential in the past. So that's the first key message. First key message is we have to do a fearless inventory. My mother says, gotta have a come to Jesus session. We gotta do a come to Jesus. What is working? What is not working? Weed out what's working and keep the rest, and that's what we move forward with in this integration process. The second key message is that I really believe, surprise, surprise, that adopting a recovery-oriented system of care framework is the way to help us in our integration efforts. Because one of the things I see as I go around the country is a strength of our field is we're not new to change, right? We deal with changing regulations, changing policies, changing administrators, changing, everything, you name it. We've had to deal with that, jump with that, realign ourselves with that. So that's a strength. I think the flexibility and the resilience that providers in this field have. but it is also, it's also a potential challenge, because as I go around the country, what I see in system after system after system, and it's not a provider thing, it's, you know, the whole ecology of our behavioral health systems, is that because the demands, the policies, the priorities change so often, what we have is a hodgepodge of stuff that's all important. We got evidence-based care practices, we have trauma-informed care, we have you know, a focus on peer involvement, we have a focus on whatever, IDDT, we've got all these different things that in any given year or few years may bubble up to the top as, this is the new thing that we have to be doing, right? Then you guys gotta scramble, realign, what does this mean for us? What does this mean for our staff? Like constant go, 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 go. You've done it well, but we shouldn't have to do that. And why continue that like madness? Because I believe that right now we're in a state where we have so much going on that things seem fragmented, disconnected. And it's very hard for people to pull this all together and say, given how fragmented and disconnected we already are, now we have to move in this direction. What exactly is that going to look like? So, given those challenges, what I'm proposing is that a recovery-oriented system of care framework, and I don't care what you call it, wellness-oriented system of care, I'm not wedded to the title. What I am wedded to are the principles, the values that guide the way in which we structure systems and we deliver services. And I believe that a recovery-oriented system of care approach is the missing link, is the framework that will help us as providers and system administrators, policy makers, people in recovery, develop a shared vision for what our services should look like, and then enter this integration process and this new era of healthcare with a common vision, common language, a really approach that's grounded in what helps recovery versus what hinders recovery. So I know recovery-oriented systems of care and ROS is probably not new to you all. But I go a lot of places, and I tell you, I hear some things out there when I ask people what is a ROSC. I say ROSC because recovery-oriented systems of care is just too long. And so, what is a ROSC? I hear some interesting things, and I just want to spend a couple minutes making sure that we're all on the same page. And sometimes it's easier to define what something is by talking about what it's not. And for me, a recovery-oriented system of care is not a model. It's not something that was done in, you know, Connecticut and can be picked up and superimposed in Maryland or Delaware, or, you know, it's not a model. It's not a template. It's not, you know, it has these components and this is what it looks like. It's not, and this is a huge one, primarily focused on the integration of recovery support services. I go places and people say, oh, we have a ROSC, because we have peers, we got recovery coaches, or we have peer specialists, and you know, we're working hard at our recovery-oriented system of care. That's great, that's a component of it, but that is not in and of itself a recovery-oriented system of care. And we'll talk more about that later. It's not dependent on new dollars. People say, we can't do this, we don't have any money. We'll see as we talk today that a ROSC is not about a new initiative, new dollars. It's about changing the way that we do what we do every day. It's not necessarily adding something, it's about changing, re-evaluating, realigning everything that you do every day through a different lens. It's not a group of providers that increase their collaboration to improve coordination, services, efficiency. Had to add that one in there because I went someplace and they were like, oh, we have a ROSC. And I'm like, tell me about it. They said, well, us three providers over here, you know, in this particular county are the ROSC. Now, we want you to come down and talk to the other folks because those other 10 are trying to get to be a part of our ROSC, and they don't understand that we already have this locked down. We are the ROSC. And I'm like, what? Okay, something went wrong. I can't make this stuff up. Something went wrong in the translation somewhere. So it's not like this closed group of people who say, you know, we are the ROSC in wherever, Baltimore or, you know, Annapolis, or it's hopefully a system-wide, community-wide transformation of how you structure your service system. It's not an infusion of evidence-based practices. Just talking to another state yesterday. We're developing a ROSC, we're so excited, great, what are you doing? We have Dr. Beck coming and we're training everybody on cognitive behavioral therapy. And that's it. I'm like, okay, good start, there's a little more. And so, but it comes from our mindset of initiatives, priorities, you know, the stuff that we've been doing. So what a ROSC is, it's a value-driven approach to structuring behavioral health supports and services. It's a network of services and supports. So one organization in and of themselves cannot be a recovery-oriented system of care. Providers say, I'm a ROSC, we have a ROSC at our organization. No, you're a part of a system, hopefully. And we'll talk about that. A ROSC is also a framework that can be used to guide systems change. So this is just Ijeoma. This is like nobody else, but these are my 6 building blocks of a ROSC that I think are pretty good. And it's basically because, again, people got stuck on one of these things. The one that they typically leave out, well, there's a few that are typically left out, but one of the ones that I think is really important that is overlooked is number 1, aligning treatment with a recovery management approach. And people think of a recovery-oriented system of care, again, as let's add these recovery support services to treatment, and then we have a ROSC. It changes everything in our system. Treatment, recovery supports, how we connect with the community, what our collaborations with primary care would look like, etc., etc. So I'm really quickly going to go through these building blocks, but I'm going to spend the most time on treatment. How many folks in the room are treatment providers? In some way you're connected to the delivery of treatment services? Okay, that's what I thought. So I'm going to spend the majority of the time focusing on the implications for treatment, but also hit the others, and then talk about how do we connect the dots. So building block 1, aligning treatment with a recovery management approach. If we do this, the impact in terms of the ACA goals are, we're going to impact quality of care, we're going to impact outcomes, and we're going to impact cost. And here's how. One of the first principles of a recovery management approach, as defined in Substance Use Disorder Treatment by Bill White, who is, always got to give a shout out to Bill, who is my mentor in all of this work, is attraction. It's about assertive outreach and engagement. If we look at our data, like I said, only 10% of people are accessing services. And of those 10%, it's a very small proportion of those who are voluntarily accessing services. The most individuals, families are connecting with services through some kind of court mandate, criminal justice, child welfare, some other kind of coercive influence. Not that that leads to poorer outcomes, because the data shows that actually the outcomes are the same, but why it is relevant is because people are coming under some kind of external influence, they're coming to you all at later stages of problem development, much later down the road, a 10-year addiction career, which is much harder to resolve than a 6-month or 1-year addiction career. So when we think about attraction, when I was in training, before I get to that, when I was in training, and I didn't say my background is in mental health and addiction. My background is as a clinical psychologist, but my training initially was in mental health. I worked with children and families, and then started working with adults, and then later started working in the addiction field with adults. And it was really interesting because it was totally separate. When I was doing mental health training, nobody ever talked about addiction. When I was doing addiction, nobody ever talked about mental health. But one of the things I remember in my mental health training was my supervisors would say to me, and back then they had the two-way mirrors. I hated those two-way mirrors. I felt so uncomfortable being watched. Because I couldn't cheat and do the things I really wanted to do, which was like hold somebody's hand and rub their shoulder, and I had to be this impersonal, blank slate Freudian thing that just had no personality, apparently. So my supervisors in mental health would watch me through the two-way mirror. They'd be in one room, I'd be in the other with the family or the client, and they give me feedback afterwards, and they say, Ijeoma, you really have a gift for this. You really can connect to people, you're empathic, you're warm, you put people at ease. You've really got potential to be a really good clinician. However, there's one thing that you are messing up that could really undermine your effectiveness as a clinician. And don't ever forget, never, ever work harder for your client than they are working for themselves. And then fast forward a few years, I'm getting into addiction work. I'm getting similar feedback. Ijeoma, you're good, you're great, people like you, you put them at ease. However, you need to remember one thing, one key thing, and that is people have to hit rock bottom and want it bad enough before you can really help them. So you're working too hard up front. They need to hit rock bottom and be ready for treatment, and then you can come guns a-blazing. Well, this quote from an outreach worker in one of Bill White's pieces of work. This outreach worker said, my clients don't hit bottom, they live on the bottom. If we wait for them to hit bottom, they will die. The obstacle to their engagement in treatment is not an absence of pain, it is an absence of hope. Every time I read that, I get goosebumps, because it's my experience in the people that I worked with. It wasn't about them not being in enough pain. It was they had no hope for the future, no hope of different possibilities for their lives, no hope that they even had a vision, a goal for their life, nothing. And in a recovery-oriented system of care, when we're using a recovery management approach to treatment, there's no such thing as the person isn't ready, they're not motivated. That might be the reality, but instead of the responsibility being on the person to prove their readiness by the intensity of their pain or the intensity of their effort, the responsibility is on us as providers to meet them wherever they are, in whatever stage of recovery, readiness, motivation they are. So that means that we have to do different things. One of the things, for example, there's a program in Philadelphia called New Pathways for Women. And I know that you all have similar programs right here in Maryland. Lena leads one of those programs. And this program in Philadelphia, they work with women who are the most disenfranchised in a particular very impoverished community in Philly. They're commercial sex workers, and most of them have histories of trauma and drug addiction, PTSD, and they are not interested in treatment. And this peer-run organization set up something that they call the front porch to treatment. They say you don't have to come into treatment just come in to our organization and hang out on the metaphorical front porch. They don't provide treatment, they just do peer support groups, they provide popcorn, they do, you know, the stuff that you get in the hotel room, the soap and shampoo and everything. They give people that stuff. People, they go into the community, do outreach, people feel comfortable coming in. And their data shows that they have been able to help 40% of the women that they have connected with initiate their recovery without even getting into treatment. Another proportion of them, they have able to successfully connect to treatment, not through here's the number and go, but let me take you, let me walk with you, let me make the phone call with you. And so they're doing assertive, warm handoffs to treatment. So when we look at attraction, assertive outreach and engagement, pre-treatment peer support programs, how are we engaging those who aren't necessarily ready for what we have to offer? Offering peer mentors as soon as contact is initiated. Another program I worked in, as soon as somebody came in the door, they were offered, would you like a recovery coach, a peer mentor? Now some of you may say, we don't have money for recovery coaches. Programs that I worked in also had volunteers who were just looking for some way to give back, for somebody to help. And I have tons of quotes that I don't have with me today, but of focus groups that I've done of people in recovery who served as volunteers. And there's one woman, Barbara, in New Haven, Connecticut. She was in her 60s. She had a 30-plus year addiction career. And she came into treatment and she said, when I came here, I was a broken, tired shell of a woman. I wanted to die. But they started to ask me to do little things. And as I started to do those little things, I started to think, hey, maybe if I could do that little thing, and I was able to do that well, maybe there's hope for me that I can do something bigger. And it was just things like somebody coming in the door, would you like coffee? How are you doing? Would you like to talk? Just being present. And so utilizing peers, developing strong linkages between levels of care through peer-based recovery supports. So looking at in your service system, in your organizations, where do people drop off? Is it between levels of care? Is it from detox to IOP? Where are those vulnerable areas where more connections would help? As you're thinking about integrating with primary care providers, who's going to help coordinate that? Who's going to help people to feel comfortable navigating that? There's also a role for peers there. And last month I was at a national council meeting, which I don't know if Kathy talked about this yesterday, but they had about 10 providers from all around the country who were talking about kind of their lessons learned in primary care behavioral health integration. And many of them were talking about how they used peers to help bridge the gap for people between primary care, their primary care experience, and the behavioral health experience. So some of them had peers in emergency rooms, some of them had peers in primary care waiting rooms, all sorts of things. So also looking at, again, assertive outreach and engagement, connecting with people before initial appointments and missed appointments. I am so sick of my dentist. My dentist actually called me in Rome 2 years ago. My telephone went off. Hi, this is Art of Modern Dentistry. We're just calling to remind you of your appointment next week. Like, are you kidding me? I'm roaming, get off my phone. But they almost stalk you. Am I the only one, or do your dentists do that too? Yeah. They call you before appointments to remind you. If you miss an appointment, they call immediately to reschedule. We haven't adopted that kind of technology, but research shows that 40%, there's a 40% increase in show rates just from reminder calls 2 days before. Again, something that when people come in, you can have informed consent. Would you like reminder calls? Are you comfortable if a volunteer peer does it? You could have a volunteer doing reminder calls until you get ramped up to integrate that into your organization. There are also organizational implications. Same-day access is something that we're going to have to integrate in our organizations. And I'm not sure to what extent people have already gone over that over the last 2 days. But NIATEX does a lot related to that. MTM Services with David Lloyd, kind of in the mental health arena, does a lot related to that. And so people are switching to concurrent documentation. Did they talk about this yesterday? Yeah? No? A little bit? Well, I'm not going to go over it in detail. When I heard concurrent documentation, I was like, what? You want me to take the note, write the note, and attend to the person in my office? And having been a clinician, I'm trying to figure out what is that going to look like. But the more I thought about it, I thought at the end of the appointment, that's really a good time to let's recap together what we've accomplished and what are our goals. What are you going to work on? What do I need to do as your supporter? And what are we going to be working on next time? And so it's an opportunity to use that again as this is your plan, person that I'm working with, not mine. So, and then I gotta mention, use the most charismatic and engaging staff. Okay, some people are client-facing, some people are not. All right, everybody let's accept that. Don't put the non-client-facing people in the reception area. So, sounds like y'all got some issues with that over there. I'm just keeping it real, just keeping it real. You go to some places, and I remember when I was in Connecticut, they wanted me to look at why was one organization having these great outcomes, another one wasn't. Simple thing. I'm saying that this is all it was attributed to. But the one organization with the great outcomes, they had a peer when you walked in the door. It was an open reception, like a living room. They had a little TV in the corner, a microwave, a phone that people could use to make local calls. They had a peer who was always there greeting people. Can I help you? You know, what do you need? Just chat with people while they were waiting. The other organization that I went to, they were serving the same population. They were actually both grant funded, serving the same population in the same community, just 2 blocks from each other. Everything was the same. Programming was the same. Everything was the same, except their outcomes. When I go into the other organization, they've got the plexiglass between them and the people coming in. So you go in and you knock on the plexiglass. And when she's good and ready, what? And this happened to me. I'm like, I'm here to see Stella. Go sit down. It's like, okay. And like the plexiglass is like, sends this message that there's something dangerous about you. There's something different about you. I need to protect myself. We're sending messages all the time where we may not even, be aware of the messages that we're sending. And there was I'm like, she needs to be in the back. Maybe filing, but not in the front here. And that happens in many of our organizations, simple things. So use people's strengths, identify what they are, put them in the right place. So another, thank God for you, because I am so technologically clueless. So another thing around recovery management and treatment, global assessments and service planning. It's another domain in how we need to align our treatment services in Iraq. If we look at the goals of treatment right now, what would you say what are we aiming for when we, are treating people? What's our ultimate goal? All the, what'd you say?
better lives.
To give them better lives, that's exactly it. And many times I hear abstinence, you know, for them to stop using. That's not our goal. Our goal is to give them better lives. It's really symptom reduction is only a means to an end. And if we can keep that in mind, that what are we really working on? That has implications for our assessment process. The questions we ask would be different. The domains that we inquire about would be different. Our treatment planning process would be different. Let me give you an example. I was doing a training a few months ago, and I asked people to see an example of the treatment plan and the recovery plan, and for this individual. And the treatment plan for this individual said, well, let me start with the recovery plan. I was really excited because the organization had recovery plans. And I was like, yes. So the recovery plan for this individual said that I would like to, I want to get into recovery so that I can take better care of, I can get a job to take better care of my 2 daughters and that be a role model for them, and also so that I can help my parents. And I thought, most people don't give us that much. Like, what great stuff to work with that this person has. They want to get a job, they want to be a role model for their 2 daughters, they want to take care of their parents. So I said, let me see the treatment plan. Let's see how these connect. The treatment plan said something like, I will, or John will go to group 3 times a week, go to his individual, and understand the consequences of his behavior and why he's gotten involved with the criminal justice system. Somebody tell me where the connection is there. So then the question from the clinician is, why isn't John engaged? I don't know what to do with him. He just comes, he sits there, and he's not engaged. I said, whose plan is this? Is this John's plan, or is it your plan? And as she thought about it, she realized, really there is nothing here that he is personally connected to. And most of our programming and the way we've approached it in the past has been from, you've come in with this problem, this is what we know works, this is what we think you need to do, X, Y, and Z, follow the rules, do it, and we'll be good. And it's not necessarily individualized to what's important to you as an individual, what are you striving to do? So if that person comes in with those goals, it's in the context of individual, in the context of groups, we're thinking about how do we get you want to get a job. What do you want to get a job in? Do you need to go to school? What do you need to do in order to go to school? And people say, Ijeoma, I'm not a life coach. I didn't get paid to go to school to be a life coach. Well, essentially we kind of are. Because when we focus just on the symptom reduction, on the abstinence, it only gets us so far. It doesn't ignite that fire in people, and it doesn't equip them with the skills that they need to, as this lady said in the front, to really have that full life in the community. So when we're thinking about our assessment process in a recovery management approach, it's much more global. When I was trained in mental health, my assessment process was look at the problem, what's the presenting problem, what are the precipitating factors, what are the sustaining conditions, what intensifies it, under which conditions, all of this stuff around the problem. I could tell you everything about the problem, but I couldn't necessarily tell you anything else about how to address that problem from that person's perspective. What resources were they bringing to this? And so, in a recovery management approach, an assessment would cover multiple domains. Spirituality, education, family, employment, children, whatever the heck they want to cover that we can think about. We're looking at what are their goals in each of those domains, and then tying that in with their treatment plan so they are personally activated and connected to something. Another difference is Right now, assessment is viewed as an intake process. We do an assessment, we come up with, this is the plan for your treatment, and go with God, follow the plan, and at the end of this plan, you will be discharged and it will be good. But if we think about substance use disorders as a chronic condition, let me just say this one thing, I'll come right over there. If we think about substance use disorders as a chronic condition, let's think about other chronic conditions, diabetes, cancer, heart disease. When you go to your doctor, any amongst us who have those conditions, they're reassessing you each time, right? And they are changing the plan according to how you're presenting at that time. So when we think about a recovery management approach, no, we're not doing a whole assessment, each time. But there's a sense of some fluidity, some flexibility that this is going to change over time, that you may have needed X, Y, and Z month 1, but now you need, you're ready for A, B, and C. And also in the context of that, it means that the services that we're providing are much more holistic. So we're not just providing, come in, we have these 3 groups, but there's a menu of options for people to select from. We've got, these life skills group, we've got X, you want to go back to school, we've got, how to get back into school, we've got resume writing, we have things that are relevant to people's lives, that are connected to what they are trying to accomplish. And people can select from, hopefully, a menu of things to help them get further along their path. I hear you. We don't have the resources for all of that, right? You know you were saying it. Let me come over here, and then I'm going to come over here.
I just wanted to say, yeah, thank you. I just wanted to say, I'm coming from the consumer perspective, and I've been in PRPs and I've been in JADE programs, and it was, I've been in groups, I've had treatment plans where they were like, okay, goal is to be compliant with meds, goal is to go, just like you said, go to group, 3 times a week. That didn't jazz me, It wasn't until I started getting beyond those kinds of goals and like wanting to go back to school. I did part of a master's degree, at a certain point, and looking beyond the program into a life with hope and a future, outside of just like my immediate goals to comply with the program, and looking into what do I really want to do with my life. That is what gave me hope, and hope is huge. In recovery, it's like you gotta look at the bigger picture suddenly and see what do you really want to do with your life, and that's what can inspire somebody to recover big time. And they start getting goals to go and become a real mom to their kids, or stuff like that. That's what really, so when you guys are making treatment plans and talking to your clients about goals, just keep that in mind, because it's the stuff that really inspires people to recover, that really goes beyond just what you guys are doing in your program. That's what's gonna, jazz people to wanna go that extra mile and do their recovery.
Thank you. Thank you so much. What was your name?
Sabrina.
Sabrina. Thank you, Sabrina. Could not have said it better. That's what activates all of us, I think, to be our best, is things that are relevant and meaningful to our lives. We had another comment over here.
I think we definitely have the staff that's interested in providing that menu of options, and they're excited about that. My only concern about this is that, we are driven we're moving to a fee-for-service world, and our organization is ready and prepared to do that. It's hard to find a way to bill for job readiness skills, which we love to do. So I think, there's some incongruency with what the clients need and want and what we want to provide for them and what in this fee-for-service driven world we can do.
Yeah.
I mean, that's a reality, I think.
Yeah.
So it's just a comment.
That is an absolute reality, and one of the things that we'll talk about is that part of a recovery-oriented system of care is fiscal policy administrative alignment. So this isn't all about what treatment providers need to be doing differently, because the reality is you're doing what you're doing because systems have evolved and the regulations have evolved to shift you into doing particular things. And I think back in the day, we did more of this kind of stuff, and things have become increasingly narrow and rigid. So absolutely want to just acknowledge that, and also acknowledge that there are programs that are finding ways to get around that. That sometimes it's how you document things. Like one program I went to, they're doing yoga with people. I'm like, how are you billing for yoga? How does that work? And I said, well, we have a yoga therapist who volunteers her time, we have a clinician in the room, and it's all about how you talk about it, like coping strategies, relaxation techniques, stress management, and how you're teaching people skills to help them in the context of their life. So resume writing could be an exercise in problem solving. It's how we got to think about how do we, it's a core set of skills. It's almost like Ryan said, you don't just think about the activity, think about the skills underneath the activity that can be applied in multiple contexts of that individual's life. And that's what we're teaching them. We're not teaching them how to write a resume. We're teaching them, you got a goal, how do you pursue that goal, how do you problem solve, how do you navigate the obstacles, how do you build your interpersonal skills, all of that stuff. So, totally agree with you, and I think until we wait for the forces around us to align with our grand vision, which will be a while, we find other ways to do it. And we're not necessarily moving to a fee-for-service model. I don't know what they've said over the last 2 days, but we're not necessarily moving to a fee-for-service model. I'm hearing a lot of people saying that we're shifting away from fee-for-service models to other kinds of models, financing structures that are, you're like, what? No, that are more like case rates, capitated rates, so things like that where you're basically gonna pay to keep this person well. You'll get, I don't know, I'm just making it up off the top of my head, $10,000 to treat this person, keep them well. I doubt it probably won't be that much, but anyway, we won't get there. And if that person, relapses, goes in and out of detox 5 times in the course of your working with them, you're gonna be in the hole. So it really doesn't matter how you keep them well, you just do what you need to do to keep them well. And that is the kind of model that we're moving to, even with, and we're far from it in the terms of the behavioral health primary care integration, because there's so many issues with just different funding systems there. But at least theoretically, that's what people are talking about, that there would be shared incentives for specialty providers and primary care providers to keep people well, and there will be shared penalties. If people relapse or are readmitted to hospitals or, recidivating, then those penalties will be shared. So primary care providers are going to be looking for, this is one thing that I do know, that they will be looking for those behavioral health providers who can demonstrate that they have the ability, the knowledge, the know-how, the outcomes to help people not just initiate their recovery, but sustain their recovery. That's where the lower cost comes in. That's where the money comes in, is not in helping people initiate their recovery, but can we help them sustain it? And that's why I think a recovery-oriented system of care philosophy is going to position us for success, because this is the piece that we haven't necessarily paid attention to in the past, and this is why we've only gotten as far as we've gotten. So, as I said, I could talk forever. I have to move along. So culturally competent approaches. As we talk about healthcare reform, the new era, more people accessing services, we anticipate that there are going to be a more diverse clientele. And one of the things that I'm passionate about is not just recovery-oriented care, but culturally competent care. And I will tell this story. You all are unique across the country, because I've told this story many times, but never once have I told the story with my husband in the room. And this is a story about my husband. I don't know if you knew I was telling this story, but now you know. So years ago, when we got engaged, which was like 20 years ago, long time. Anyway, moving right along. He said, oh, I know your father's from Nigeria. I grew up in the Bahamas. My mom's Bahamian, my father's Nigerian. So those of you who heard me before may have heard me tell this story before. But Tim said, I want to do the right thing, come to the Bahamas and ask your dad for your hand in marriage in person, because I know he's very traditional, I want to respect him, and I don't want to screw this up. So we go out to dinner, he has some kind of nervous reaction and spills the glass of water all over my dad's lap. After we get over that, sorry Tim, after we get past that, you know, he makes his big announcement, and my father says, yes, absolutely, you're like a son to me already, and welcome to the family, and all that good stuff. He said, but one thing, I need you to know that I'm going to need you to bring me some cows and goats for my daughter. And Tim looks at me, and I don't know what the heck he's talking about. So I'm like, ha ha ha, I start laughing, so Tim starts laughing, and that was the end of it. And my dad, shortly after that, got sick. He got leukemia, and he went to Houston for treatment, and every time he would call me, he would say, is Tim working on the cows and goats he didn't forget? Or he would talk to Tim, don't forget about my cows and goats, I'm waiting. And we would laugh, because I grew up in the Bahamas, and I saw my Nigerian family every once in a while, but nobody mentioned anything about any cows and goats. So I didn't know what he was talking about. So we got married about a year later, and my father unfortunately passed away 10 months after we got married. And his desire was to be taken to Nigeria and be buried there. And so we did that. We took him to Nigeria, and we got there the first night. We were out in the village. Now Nigeria has skyscrapers, cities, you know, like New York, but we were in the bush. Everybody say the bush. The bush! That's where we were. There was nothing out there. And Tim's like, you know, New York man, like, where the heck am I? So we're trying to sleep that first night, and there's a knock on the door. And there's no, we're just trying to get some sleep, and Tim's like, you know, or maybe it was me, was like, okay, maybe we'll ignore it and they'll go away, but no. Like, okay, Tim, you were called. We're like, called? What? The men in the village are waiting to see you. Tim's like, what? I'm like, okay, honey, we gotta go. Now, in Nigeria, you don't mess with the family request. You get, and it's not really a request, it's a command. Just put your clothes on and come on down. So we get ready, and we have to walk from my uncle's house to my grandmother's house through this brush, and you know, it's far away, and we have this flashlight, and we're walking through the thing, and Tim's like, what's going on? Where are we? And I'm like, don't worry, baby, I got your back, I got your back, I got you. We got this. So as we get closer, we see this campfire, and this fire and there's like 100 men around this fire, the elders in the front, and they're talking Igbo, and they're going back and forth. I got any Nigerians in the room? Woohoo! We are intense people, right? Intense when things are good. So you can imagine when things are not good. They were not happy. So we get there and they tell me, this is not women's business. Go to the house. This is men's business. I'm like, all right, baby, peace. I'll see you later. I'm out. So I leave Tim with, to fend for himself. He's standing there for once in his life, speechless. And they're going back and forth, he can't understand what they're saying, and finally somebody starts translating. You have taken one of our beautiful Achara princesses, and you have brought us nothing. No cows, no goats, nothing. And they are serious, and Tim is just like, am I on candid camera? Like, what is going on here? And my uncle from the Bahamas, my Uncle Danny, had known Tim and known my Nigerian uncles. And Uncle Danny said, okay, he saw things heating up. He's like, I gotta come to the rescue. So, Daniel, can you join me, please? Can I borrow you? You're like, darn. So, I'm Danny. This is Tim. Uncle Danny puts his arm around Tim and says, we have done a thorough background investigation. We have checked out Tim's family. He comes from good people. He comes from good stock. And he will buy the cows and the goats tomorrow. Right, Tim? That's pretty much what Tim said. Right. Now, there is debate in the room between my husband and I about how much he paid for these cows. I'm not going to go there because, I don't want to start any marital conflict, but I heard a rumor that there was $20 a piece for some mangy-looking cows for me. For me. However, if anybody wants to come to my defense, that is him right there in the pink, and handle it with him. Anyway, let me get back. Let me get back to the topic at hand. You're like, how does this relate to healthcare reform, recovery-oriented systems of care? It connects. After this trip, I thought about, Tim thought he was doing everything right. Thought he was being respectful, asking for the hand in marriage, making the trip to ask in person, doing everything right. But he had a completely different cultural lens, a completely different cultural context. When he got into a different world, he found that those things mattered zero, less than zero. They didn't care about asking for the hand in marriage. Where's the meat? Pretty much. And how are you going to show us respect in the way that is respectful and meaningful to us? And I thought about how many times people come into our systems and there's a complete cultural divide. It may be ethnically, racially, it may be somebody coming from criminal justice system into a treatment system who's not making eye contact, and we're wondering, why aren't you making eye contact? That's disrespectful. Why aren't you participating? That's disrespectful. When they've learned some different survival mechanisms in a completely different culture. So there's so much that I could go into around culturally responsive services. But as we go into healthcare reform, really thinking about who are we serving? Are there any disparities in terms of the access, engagement, treatment outcomes in terms of the populations that we are serving? And based on those disparities, what could be driving them? Is it that people aren't comfortable? Is it that people aren't feeling that what's important to them, what's relevant to them is being addressed? Is it that there's a mismatch in terms of the ethnic, racial representation of staff versus those who are being served? There's so many things. but we're not going to know until we ask the questions and pay attention to those factors. I was like, okay, next, and I'm like, okay, I have it. Okay, I got to put my skates on here. I told you I'm a talker and I'm passionate about this stuff. Collaborative service relationships. Quick story, in early days in training, had a woman come in for depression, anxiety, substance use disorder, and I thought, great. She's an African-American young black woman. I thought, she's black, I'm black, she's young, I'm young. We're gonna get along great, we're gonna hit this off. And she tells me her challenges, and I go away all excited, look up my cognitive behavioral therapy, come back to the second session. I've got the plan, I've got it worked out, this is what the treatment protocol is gonna look like, I'm gonna use CBT, don't worry, you're in good hands. Third session, what happens? She doesn't show up. And my supervisor says, don't worry about it. Well, I think the first session, it was like no issue. Second session, she didn't show up. Supervisor said, go to the wait list. We got more people, she's not ready. I didn't feel comfortable doing that. I'm like, okay, it's raining for the last 2 weeks, you know, black women in their hair, maybe it was the rain. But no, third session, she still didn't come. And I finally, Ijeoma got a clue and said, maybe I should reach out to her. So when I called her, she says, well, I didn't think you needed me there. I said, excuse me? She said, well, it seemed like you were having a good time all by yourself, so I don't want to get in the way of that. And I was never able to successfully re-engage her. And what the message for me in that was, when we think about traditional treatment models, we have a very hierarchical, expert-oriented approach. We come in with the answers, that's the way that we've been trained. But in a recovery-oriented care approach, we shift to a very collaborative partnership approach. So we're working together as partners. I'm your coach versus your, teacher telling you what to do. It's a shift in the power dynamics. Okay. Chronic care approach with continuing support. When we look at continuing support in addiction services, we look at relapse rates, compliance rates that are very consistent with the rates in other chronic care conditions. Diabetes, hypertension, asthma, all of the compliance and relapse rates are between 30 and 80% for substance use disorders and those other physical health disorders. But what's different is the way that we treat those different kinds of disorders. I know it's been 3 days, but listen to this statistic. And I know I lose people on stats, but this is an important one. It takes 4 to 5 years for the risk of relapse to drop below 15% in alcohol addiction. 4 to 5 years for the risk of relapse to drop below 15%. That is similar to breast cancer, when it takes how many years for a doctor to say you're in remission? 5 years. What happens in the 5 years that a woman has breast cancer? Do they do the chemo and then say, okay, you're done, bye? They have ongoing support, checkups, regular support, early intervention if necessary. We have the exact same time frame, but our model is treatment, brief period of treatment, and bye. What did I say earlier? That in the first 3 months following treatment, people are at the greatest risk of relapse. First 3 months. But in that 3 months, we say go to 90 days, 90 meetings in 90 days, and, kind of go with God. So in a recovery management approach, this is one of the critical areas. If you're thinking about how do we be successful in our primary care behavioral health integration, this is one of the linchpins. That once you help that person stabilize, initiate their recovery, they need ongoing support, continuing care. And that continuing care doesn't start 2 weeks, 3 weeks before discharge. Then we start thinking about it, which is the way I was trained. It starts session 2. Who in your community is available to support you? What's your community recovery capital? Is it your church, your pastor, your barber, your hairdresser, your cousin? How do we engage these people in this process? Oh, it's nobody? Well, how do we begin to build that so that when they are discharged, they're discharged into a network, a community of supports? Which of these people do you feel comfortable being a part of this process with you? We're developing a community care plan from day one. It's completely opposite to the way that I was trained, but critical for a recovery management approach. Building block 2, integrating recovery support services. When I was doing clinical work, I felt like I was just doing a drop in the bucket. I loved it, but it was so hard. And it was so hard because people were dealing with poverty, transportation, housing, child care, lack of education, challenges in the criminal justice system. I, little old EJ, could not fix all of those problems. I couldn't do it. And the more and more I tried, the more I felt like I was burning out, spinning my wheels, and feeling frustrated. I would have successes here and there, but for the most part, it just felt like I was working so hard and not having the impact that I wanted to have. Anybody ever feel like that at any point in their career? And some of this, when we talk about recovery support services, sometimes I hear, particularly around peer support services, well, is this, is there some agenda to kind of replace clinicians in the future with peers or get cheaper workforce? Or no, I go back to the simple, it takes a village. I could not do it. We cannot do everything that it takes to help somebody rebuild their life in the community. It's going to take those partnerships, not just with primary care, but we have to have partnerships in the community that we come to when we approach primary care, those folks who can provide the recovery supports in different stages of recovery. So pre-recovery engagement. Those recovery supports might look different for those who are in recovery maintenance. Recovery maintenance is, how do they maintain their recovery? Housing, a job. Somebody who's in recovery and initiation and stabilization, they need recovery supports that are around basic life skills. And then enhancement of quality of life. How do we help people achieve life to the fullest? So there are different kinds of recovery supports that are relevant for each person's stage of recovery. And these are just examples. I believe that you will have access to this presentation. Is that right, Linda? So the detailed examples you'll have access to. This is just a recovery community organization in Detroit, which I am totally blanking on the name. But it's not in Detroit, it's in Atlanta. And it's Recovery Consultants, started by David Whiters. And they did a collaboration with a faith-based community, and they developed an entrepreneurial program where they have a program to help people either start or be a part of an entrepreneurial business. And what they focused on is home repairs, painting, power washing, those kinds of things. And they said they started with one van, they now have tons of vans, and they have a corner on the market in Atlanta. And again, it started very humbly with a recovery community organization, peers who said, people need jobs, how can we partner with faith community? So as providers, we can't do all of this, but how do we identify those who are either interested in doing it, supporting them, or who are doing it and collaborating with them? Developing a culture of peer leadership and support. This is another critical piece because for me, developing a recovery-oriented system of care isn't just about, oh, let's integrate some peer support. Let's get peer specialists specialists, let's get recovery coaches. In the physical health arena, they're talking about activated patients. That they need activated patients who are taking charge of their health and wellness, their recovery. We've been talking about this in behavioral health. We don't talk about patients, but we talk about people, client-centered services, consumer-driven services, client-driven, client-directed services. So people taking charge of their own health and wellness. And what we want to see is not just people who are in our services passively receiving, but the most innovative, ignited kind of organizations that I have had the pleasure of working with, learning from, are those that had activated leadership councils of people in recovery who are a part of helping to identify what the programming should look like. They may be a part of helping to monitor programming. They may be a part of helping to evaluate what's going well, what isn't. They're doing focus groups. It creates a different energy in the environment. How many of you have that? And it's not just, oh yeah, we have a council, they come together and they, have cupcakes once a month, and, I'm talking about they have a presence in the organization that people can feel, see, touch, and their impact is known. You guys, do a shout out. All right, that is great. I think that's what we're wanting to see more of in our field, and we're so close to that. But I think that's going to be really critically important in the next phase of our transformation process. The fourth building block is around promoting community health and recovery capital. Real quick, Bill White told me this metaphor, which I think came out of the Native American community, and it's basically that this community had a very prized tree that was like the prize of the community, beautiful, flourished, and it was a treasure in the community. And they saw that the tree started to wither. It started to dry up. And they knew it was because the soil in which the tree was planted was diseased, had become sick and diseased. And they thought, in order to save our tree, we have to get this tree out of here and replant it in another forest. So they did that, dug it up, replanted it. Trees started to flourish, bloom again, beautiful, healthy. So they're like, oh, we've got our tree back. Let's take it back to our community now. What happened when the tree went back to their community? It died again. The diseased soil got it. What is my point? I go off on these tangents that you're like, okay, where is she going now? My point is that historically, we have taken people in the past, we've taken people out of their communities and said, you have to get away from people, places, and things, get away from your environment in order to initiate and sustain your recovery. What happened when we took people back to their communities, or they went back? They were around the people, places, and things, and they relapsed. And this one guy told me, he's like, look, unless y'all have a relocation program that I don't know about, stop talking about a getaway from the people, places, and things, because I live across the street from the crack store, the crack house, the package store. I'm not like going anywhere. This is my home. And so as a part of recovery-oriented systems of care, part of the message, the mantra, and I'm really excited that physical health is now starting to embrace this also. There was a whole 2 journals in Health Affairs magazine for the last couple months on the importance of promoting community health. The understanding is that we can't just focus on the individual. We have to focus on the community in which the individual is embedded, because we each are only as healthy as the community, the family, the environmental context that we're in. So you're like, now I gotta be a community change agent? No, but we have to partner with those that are. We have to be strategic about, okay, if you're gonna be held responsible for keeping people well, and your bottom line is gonna be, impacted by the extent to which people stay well, It is in our best interest, not only for that person, but for the survival of our businesses to help our communities flourish. And there are systems that are doing that. And this again is not, I'm talking kind of at a treatment provider level, but I say the exact same things to system administrators, and things like this are even more relevant for them. You cannot do this all on your own. I understand that, but these are the concepts, the direction that we're moving in. This is a wall in Philadelphia. They got people in recovery and community members together and said, what would recovery look like in our community? And they have these all around the city. Aligning administrative structures. Key point, we're not there yet, we need to get there. 3 approaches to developing a ROSC. And this is what I and some of my colleagues, Arthur Evans and Joan King, developed. And it's about the ways in which systems go about thinking about or developing a ROSC, an additive, a selective, or a transformational approach. And for lack of time, I'm just going to go to the additive and transformational. Additive is when we say, we've got our system in place, now we're going to add recovery support services, peer support, we're going to add, clinical care coordinator in the primary care environment, we're going to add a health navigator, like we're adding stuff to what already exists. That is going to have only limited success. A transformational approach, and that may be the place where you start developmentally, but a transformational approach is, let's look at the way in which we do everything that we do it through the lens of recovery, what helps and what hinders recovery, and realign everything with that approach. From our services, practices, policies, fiscal strategies, the whole 9 yards. So, some of you were thinking, woohoo, this is great. This was the best presentation of the 3 days. Yes! I know. Others are thinking, this is nice, but we don't have money, we don't have time, I don't have the staff, the regulations aren't aligned. How do I know this is the direction that we're moving in? Well, I did a side-by-side comparison of ROSC principles and behavioral health primary care principles. And you will see that everything that we're talking about in terms of a recovery-oriented system of care is everything that they're talking about in terms of behavioral health primary care. The language might be different, but the concepts, the principles are the same. We're talking about shifting to a chronic care approach. That's what I've talked about. That's everything that is through health reform and primary care, behavioral health integration, healthcare homes, all focused on chronic care approach. They're talking about, for instance, a whole person orientation. We've just been talking about the need to focus on not just symptoms, but a holistic approach to the person. They're talking about a public health approach that focuses on whole health population outcomes. We just focused on community health and how do we promote community health and wellness. It just goes on and on and on. They're talking about activated patients. We're talking about choice and self-direction. They're talking about shifting from individual practitioner models to a team-based approach. So you wouldn't just come in and see your individual doctor, but you have a team of people that you work with. We're talking about expanding the composition of service teams. So it's not just an individual, but person in recovery, your doctor, a whole team approach. So it is absolutely consistent. And that meeting that I went to in Chicago with the National Council last month, these are some of the lessons learned that those individuals said, and I just wanted to highlight the first one. This provider who's identified as one of the national leaders in behavioral health primary care integration said, it can't be about just adding services or changing practices. It has to be viewed as a cultural change. And the last point that another person says, this requires attention to leadership and change management. It's really about not, let's tweak this over here or tweak that over there. That's reform. We've been there, done that. That's not transformation. That's not going to get us to where we want to be in terms of better health, better care, and lower costs. So these are my final 4 closing slides in my, what do I have, 5 minutes? 7. I'm good. Capitalizing on the opportunities, where do we go from here? And just 4 key messages that I hope will help you to synthesize a lot of the things that you've probably heard over the last 3 days. The first is, okay, you leave this place, you know, in a few hours and you're like, man, I was bombarded with tons of information, now what? What do I do with all of that? One area of focus is identify the recovery-oriented practice changes that will improve access, quality, and outcomes in your setting. So based on what we've talked about, where are your challenge areas? Is it in terms of access? Is it in terms of retention and engagement? Is it in terms of you getting people stabilized and initiating their recovery, but they're not sustaining their wellness? Is it in terms of helping people build that full life in the community? And then identifying what are some concrete things that you can begin to focus on. Is it changing your assessment processes? Our assessment processes are going to have to change when we integrate with primary care. They're going to have to be more global and holistic. Let's start that now. Let's not wait. Our service planning processes are going to have to be more individualized and client-centered. Where are we in that domain? Do you need more pre-treatment recovery support services? We talked about continuing support. Many programs are starting to do recovery checkups on the back end of treatment. You can Google recovery checkups, or you can go to williamwhitepapers.com and get a lot of information there from Bill White's website, has tons of resources. Do you need to integrate peer supports or assertively link people to different levels of care? So my point is, the first step is get a vision for what recovery-oriented services would look like in your setting. Don't run to, oh my God, primary care, like we gotta integrate like today and now we're here and now what? While you're building those relationships, partnerships, and getting that going, also be thinking internally about what do we do well, what makes us our best, what do we need to be doing better, and how can we improve our recovery orientation. The second area of focus, leaving kind of these 3 days, is identify key organizational and administrative changes that need to occur in the short and long term. So I'm sure you've heard a lot of things. What are 1 or 2 things that you're going to take away that in terms of your organizational structure needs to be realigned? Is it around concurrent documentation? Is it same-day access? Is it streamlining paperwork and duplicative processes? Is it improving how you use data so that you have data-driven decision-making? That's going to be key going forward. Do you need to build an infrastructure so that you can use data, so that you're collecting data? You can't do all of this at once. You know, we would just all crawl up under the covers and not want to get out of bed. But you bite off, what can I tackle, chew, kind of over the next 6 months? And what's going to get me the biggest bang for my buck? Not necessarily in terms of money, but in terms of the impact in my organization and the quality of my relationship with future partners. Identify your change management structure and process. This is so critical. For those of you who are in leadership positions in your organizations, or you're going back to report to leadership, people just wishing that this is somehow going to happen, it is not going to happen. There has to be a point person, point people, a team, whatever you want it to be, who is charged with the responsibility of helping the organization navigate through this. Because we're busy. We're already pulled in a million different directions. And one of the key things I learned in Connecticut and Philly, where I was charged with the recovery transformation process there, was If there's not a point person in charge who's accountable and whose at least part of their job is to shepherd this process, to monitor it over time, to figure out how we're going to communicate it to the staff and get people invigorated and engaged and excited, it's going to die before it even gets out the gate. And one thing that I heard from one of the providers at that meeting was, they said that this is kind of radical. I'm not saying you should do this, on Monday, but they took a radical approach. They fired everybody in the organization the next day, and they said, we are going, now they didn't do it like out of the blue, but they had been talking about, we're changing our direction to recovery orientation. This is the direction we're going in. They fired everyone, and then they said, we invite you to be a part of this. We want you to be a part of the future of this organization, but it's your choice. You don't have to be. They clearly articulated the direction, they clearly articulated their intention, and then they said, we invite you to be a part of the changes that are going on in this organization. We believe you have a valuable role to play. So people felt empowered, felt chosen, felt they had a choice, but there are those who aren't going to want to come along, and that's a part of the reality. And the final thing is developing strategic partnerships. I'm sure you've heard a lot about this in the last few days. We have stuff to offer. We are the bomb. They need us. Don't go out thinking, oh my God, I gotta find somebody and poor and Hannah, poor me, oh my God, I'm gonna get left behind. They need you. People don't want to do what we do, and they can't do what we do. You are in demand. You are a commodity. If you think poor, you're going to be poor. We have to think differently. Think that you are the bomb, okay? Because you are. And identify who are the strategic partners that you want to connect with. Critical point, what are their most urgent needs? Don't go in with what's important to you. Find out what is important to them. Is it the people who are coming into the ER over and over again? What's keeping them up at night? And then you have a solution to address that. That is what I have seen be successful in these kind of cross-systems integration efforts. Finally, you're the bomb. We can do it. Let's go for it. Thank you.